I think intralesional therapy really has come a long way. TVEC was approved actually 6 years ago now, and since then we made a lot of headways. I think that we're still struggling though a little bit, trying to figure out especially what patients to choose for this, the tumor types, and also how to combine this. And recently there were 2 studies in melanoma specifically that looked at using, in one of them, TVEC in combination with pembrolizumab in the first-line setting in patients with melanoma. And unfortunately, that study did not meet its primary endpoint. There was also another study using a TLR9 agonist, an IDERA compound, Atezolizumab, in combination with ipilimumab in PD-1 refractory melanoma patients. And also, unfortunately, that one did not meet its primary endpoint either. So I think this put a bit of a damper on the intralesional therapy community and how we use these drugs. However, I think we have to recognize is that there still is a role for these compounds. And the symposium that we had yesterday, I really think highlighted this, is that how we now better understand the tumor types that are more likely to respond, and also how to combine these. And also, which was pointed out yesterday as well, is that when we inject these intralesional therapies, they're not all the same. And really understanding the mechanisms of each of these is very important. So moving forward, what we're doing, we're really trying to have a consensus group or consortium put together to really look at the patients that we select for these studies, the tumor types, and also try to understand the biology and understand really where these therapies can have the best impact on helping patients with cancer. So more of this will happen over the next few years, but I think that the horizon still is bright for these therapies. With respect to that, we actually have a poster here that we're looking at the combination of a Coxsackie virus A21 in combination with ipilimumab, specifically in patients with melanoma that have progressed on previous PD-1 therapy. And there, we actually showed that we can have a great impact on improving responses in these tumors. And also, we can have a great impact on really having a robust immune activation. So I think that this is one way forward where we really have selected patients that we can choose, that we know that have a good probability of response in their tumors. So this, I believe, is a mechanism for us to move forward to really understand the mechanism of actions and the immune activations for these products. Another way to look at this is that many of these intralesional therapies, specifically the toll-like receptor agonists, have been used in patients with melanoma, but also many other tumors. And the method of delivery has been intralesional injection. Although this mechanism does work for many patients, there's still, over 70% of all patients with metastatic disease that don't have lesions that we can inject easily. So I think that we need to look at other ways to overcome, so we need to look at other ways to treat these patients that have disease that we cannot easily inject. And that's one of the abstracts that our company is now presenting, looking at the TLR7 and 8 dual agonist that we deliver intravenously. And we actually show that we can deliver this safely. Patients actually tolerate this very well. The most common adverse events are really grade 1 and grade 2 fever, shakes, and chills. And we have very few grade 3 toxicities, and we've had no grade 4 and grade 5 toxicities. And I think that this method then really allows to be able to give these toll-like receptor agonists that activate both the innate and the adaptive immune system to virtually all patients, not only patients that have a lesion that we can inject. In addition, in this poster that we presented with respect to this, we combined our BDB001, our TLR7/8 dual agonist, with atezolizumab. And we showed that we can see responses in patients that have tumors that are refractory to PD-1 and PD-L1 therapies. And we saw this specifically in urothelial carcinomas and also patients with non-small cell lung cancer. We also have a large number of patients that have very prolonged stable disease. And this in itself is important, specifically in many of these phase I studies where patients have been on 4, 5, 6 different lines of therapy. So getting this prolonged stable disease is also important. Additionally, what we show with this is that we are able to activate the immune system by giving this toll-like receptor 7 and 8 agonist intravenously. So we have robust upregulation of cytokines and chemokines, including IP-10, also known as 6CL10. And this really is a marker of the ability to activate the immune system and generate their response. And we know that in patients that have a response or prolonged stable disease, they tend to have a very robust upregulation of IP-10. One of the concerns by delivering one of these TLR7/8 agonists intravenously is that do we have cytokine release? Do we activate IL-6 and other cytokines that have been associated with cytokine release? And fortunately, we can say that we, with our compound BDB001, we really don't seem to have that. So we really have shown that we can give this compound intravenously safely. We get robust immune activation, and we see responses in multiple tumor types, and specifically in tumors that are PD-L1 negative, tumors that are TMB low and MSI stable, and tumors that have previously been treated with PD-1 and PD-L1 therapy. So very difficult to treat tumors. So we are very encouraged by this, and we are moving this forward into a phase 2 setting, where we'll evaluate this further in more specific tumor types.